Thank you everyone for coming. I have the honor to introduce Professor de-Graft Aikins, and I have a bio here, so I'm just going to, I think it's a summarized one. de-Graft Aikins is a professorial research fellow at the London School of Economics and Political Science and a professor of social psychology at University of Ghana. She received her PhD in social psychology from LSE. She completed postdoctoral training at the University of Cambridge and has held teaching and research positions at LSE, University of Cambridge, University College London, where she was a British Academy Global Professor between 2019 and 2023. Ame's research focuses on chronic illness experience and care, arts and health, and the psychosocial drivers of Africa's chronic NCD burden. She has taught, supervised, and examined graduate students, mentored early career researchers based in Africa, many European countries, America, Australian universities on these research areas that I just mentioned. Her current research project includes the British Academy Seed funded Chronicity and Care in African Context project, a Wellcome Trust funded project. It has an acronym, so HAPVIA, not sure what that stands for, but it seeks to co-produce community-based heat adaptation strategies in Ghana and South Africa. And then the Horizon Europe funded MCare project, which seeks to improve the care of patients with multiple long-term chronic conditions in Ghana, Kenya, and Uganda. Her recent book, and I think she has a copy on the table, please have a look at it. The book is called Selling Healing, Creative Arts and Health Communication in Ghana. It was published by the Cambridge University Press, is a major output of the Chronicity project. And I must say I had a privilege to review that book at Oxford last year. And I think it was my comments that was selected by the publisher. Yeah, I was really proud to see that, my comment had been selected. So yes, I'm one of Ama's mentees as well. So I invited her to come and share some of her work with us here. So Ama, over to you.
Good afternoon, everyone, and I am very honored to have been invited to come and give a talk this afternoon. Thank you to Hiba. Thank you especially also to Paula for coming and for supporting this. When Hiba invited me, she said, my talk had to focus on sort of global health, because it's IAS and it allows us to talk about interdisciplinary themes. And so I thought I would sort of select some case studies from the book that Hiba mentioned in the introduction. And I'm just going to dive right in, try and do it in 30 minutes so we can have time to talk. I'll start with the case study on Mr. Wise and Mr. Foolish go to town. So in June 1944, a letter arrived for the Gold Coast governor. The Gold Coast was Ghana's name then in the colonial era. This letter arrived from the colonial office at Downing Street, London. The letter proposed to dispatch a silent 35mm film on the subject of sexually transmitted diseases among Africans. The film had been originally produced in South Africa on syphilis prevention for mining communities and had been titled The Two Brothers. But when it came to West Africa, the title was changed for unexplained reasons to Mr. Wise and Mr. Foolish Go to Town. The story was simple. It said, the film attempts to point out the moral of two Africans, Mr. Wise and Mr. Foolish, who both contract the disease syphilis, but who separately go about their cures in different ways with fortunate and unfortunate consequences respectively to themselves and their families. Two further facts emerged in subsequent communication. Both men had contracted syphilis from their extramarital affairs. Secondly, Mr. Wise went to see a colonial doctor and was cured. Mr. Foolish went to see a medicine man, that is a shrine priest or a herbalist, and remained sick. In order for the adaptation to be approved, I mean, several letters were sent to heads of important institutions of the day in the Gold Coast, medical services, education, Chamber of Mines, missions, the military. A special board made up of a subset of the letter recipients was established to assess the suitability of the film for local audiences. Eventually, a viewing was held at a local cinema in Accra for a broad group of elite adult men, missionaries, lawyers, businessmen, press representatives, African inspectors of schools, teachers, and so on. And the reaction to the letters and to the viewing was mixed. The acting director of medical services argued that gonorrhea was a much bigger public health problem than syphilis. He also observed that the uniform worn by Mr. Wise's girlfriend was too similar to the uniforms worn by Gold Coast nurses. It was likely to cause an intersectional class war. Others felt that if the narration was too serious, the film might make people laugh too much, which would defeat its educational purpose. For those who were of the view that the Gold Coasters were too primitive, the voiceover needed to be done by an educated person with an authoritative voice. Some suggestions were made on suitable audiences for the film, miners in gold mining towns, schools and colleges, youth societies, and the like. But ultimately, the consensus from local experts was that not only were both men foolish, but the film itself was also foolish. So Mr. John Wilson, who was the Gold Coast PRO, says, the film shows both Mr. Wise and Mr. Foolish making their arrangements for illicit relationships without a hint that they're acting foolishly. The director of education said, it seems strange that no section dealing with the prevention of disease was included in the film. If ever special films were prepared for West Africa, I feel it would be most wise to include such a section. Mr. Wilson, the PRO, wrote very detailed recommendations to Downing Street on how to change the film's contents, the language, and delivery. It's difficult to know whether minors in Takwa, school children, youth societies ever saw the film because there's no further material on the campaign and the archival records after Mr. Wilson's final letter in October 1944. But the months-long discussions and anxiety around having the film backfire spectacularly across all social classes in the Gold Coast suggests that the original idea had not been thought through critically. And once some thought had been applied to content, context, and impact, the Downing Street officials and their allies decided quite wisely to quit while they were ahead. Now, Mr. Wise and Mr. Foolish Go to Town is one of the more prominent colonial attempts to apply arts to public health communication in the Gold Coast. It stands out as a case study because the records clearly track the way the colonial public health and public policy machinery operated, from conceptualization of ideas to implementation of a project. The letters and reports highlighted the racialized, gendered, and class dimensions of colonial policy making. They also revealed the ideological tensions between colonial medicine and indigenous medicine. In the archives in Ghana and in social history accounts and colonial era health interventions, other arts projects are documented. Some were implemented prior to Mr. Wise and Mr. Foolish, others after. American social historian Jean Ullman describes a baby show which was launched in Kumasi, the second biggest town in Ghana, in 1925. The show ran annually, and by 1929, Ullman says it had transformed completely into a mechanism of social regulation, if not social control, of colonial motherhood. Now, this project was part, she argues, of a broader British imperialist project of making proper mothers at home and in the colonies, in Africa and elsewhere. The Mothercraft project was entrusted with and implemented by what she calls maternal imperialists. These were missionaries, nurses, teachers, women medical officers who conducted baby bathing demonstrations as well as cookery with a focus on British pancakes and biscuits, sewing, gardening, reading lessons in colonial mission spaces, as well in the private homes of Asante mothers. In the 1940s and 50s, food fairs were organized in Accra and in other towns at which local and regional cuisines were displayed and sampled and collated for the publication of a colonial cookbook. In many cases on record, ideas were developed in London, usually at the Colonial Office at Downing Street, or at public relations firms in central London, with minor contributions from West African subsidiaries and brought to the Gold Coast for tweaking. What tied these arts-based interventions together, though, was their embeddedness in the broader colonial medicine project. This project was not benign. Frantz Fanon, the Algerian psychiatrist, revolutionary, and post-colonial theorist, theorized about the way African psychological realities were conditioned by relations of racialized power and violence during the colonial era. He called these intersections of psychological and sociopolitical conditions the psychic life of the colonial encounter. And this psychic life was double-edged. From the European side, colonial medicine was often violent. The story on sleeping sickness in countries colonized by the French is particularly instructive. Painful examinations, such as penile taps, were performed on entire villages, often under gunpoint by soldiers protecting traveling medical teams. Treatments, such as the drugs atoxyl and lomidine, were more harmful than the disease itself, causing blindness in 20% of recipients and death in many more. In the Gold Coast, sleeping sickness campaigns introduced new infections in northern communities. At the heart of public health campaigns and medical experimentations and treatments was the notion of the African as a pathological museum. American historian Melissa Grabois observes that this notion captured the European researchers' amazement at, and I quote, the collection of germs, pathogens, viruses, parasites, and other abnormal and unusual diseases likely to be found in a single African body, end quote. The pathological museum wasn't only a description of diseased African bodies in the tropical field. It was also a real place. Biological specimens from African bodies, bodily fluids, diseased organs, skeletons, and so on, were transported to actual pathology museums in European medical schools in Britain, France, Belgium, and elsewhere. There, trainee doctors and medical researchers who planned to work in the tropics were able to see representations of diseases they were unlikely to see and could barely imagine in their own countries. These medical spaces were no different to European museums housing looted Benin bronzes or Asante gold, or botanical gardens nursing exotic plant species with Euro-American names. And in the same way that the African artifacts and flora shaped the fields of museology and botany, these biological specimens form the building blocks of colonial medicine and various laboratory sciences. But what colonial medicine did to Africa was one side of a complex story. The other side was how African communities anticipated, saw through, worked around, and resisted medical violence in very similar ways to political resistance to colonialism itself. Veteran Ghanaian journalist Cameron Dodo recalls his childhood days in the colonial Gold Coast when he says, all the smart people in our villages tended to run away from vaccination because colonial authorities were uncommunicative and behaved like gods, end quote. When art-based health interventions were implemented in cities and villages in the Gold Coast, they carried the same air of uncommunicative, godlike behavior, and they were seen by local communities as an extension of the colonial medical project. Projects that sought to impose a British way of doing things were rejected or were transformed into versions that served local needs. Colonial medicine established a trope of Africa as a conduit for infection and set Africa as a familiar alien threat in the global imagination. Notions such as the African as a walking pathological museum have morphed into contemporary versions such as the African AIDS epidemic and more recently, the African COVID paradox. I'll move on to the second sort of set of cases. During the first year of COVID-19, the discourse on Africa in global health and global politics took a predictable stigmatizing path. In April 2020, two senior French medics were talking on a French television network about the possible use of the BCG tuberculosis vaccine to treat COVID-19. One observed casually, if I could be provocative, should we not do this study in Africa where there are no face masks, no treatments, no ICUs? A bit like it's done for some studies on AIDS, where with prostitutes, we try things because we know that they're highly exposed and do not protect themselves. The other medic agreed. The reaction on African Twitter, now X, was swift. The WHO's Director General, Dr. Tedros, publicly rebuked the medics, calling their remarks racist and a hangover from a colonial mentality. As death rates rose in Europe and North America, the narrative of Africa as the world's lab for COVID-19 vaccine development shifted to a narrative of Africa as the world's imminent COVID-19 grave. Global health experts predicted catastrophic mortality rates in Africa. Estimates range from 300,000 to 3.3 million deaths. In an interview on CNN, the billionaire philanthropist Melinda French Gates remarked, "Look at Ecuador, they're putting bodies out on the street. You're going to see that in countries in Africa." When these predictions failed, the African COVID-19 paradox was coined. One group of US-based epidemiologists defined the idea as follows. Despite its crowded social life and poor personal hygiene practices, case fatality of COVID-19 has been paradoxically low in Africa compared to the Western world, end quote. The core message of the African COVID-19 paradox, why a predicted catastrophe did not materialize in most African countries, despite their fragile health and social systems, did not capture the lived reality of epidemiological complexity that forges sociocultural creativity and resilience. In Ghana, public understanding and practices developed in ways that mimicked responses to previous health threats, such as HIV/AIDS, Ebola. Even before the government imposed a partial lockdown in March 2020, traditional and social media had given Ghanaians a taste of what ordinary people were thinking about the pandemic. There were countless vox pops and WhatsApp videos of market women, school children, public transport drivers, people going about their daily lives, expressing their colorful views and inventive concepts on the new English scientific terms that the Ghana Health Service used to explain the pandemic: coronavirus, social distancing, respiratory hygiene, super spreader. Terms blending pidgin English, local languages, a blend of English and local languages emerged. Interventions were proposed, such as greeting with elbows, ankles, and other body parts, and using local home brews as hand sanitizers and stress relievers. Ghana's creative arts communities captured the complex facets of this pandemic and social responses through various art forms. So we had sort of comedy, songs, murals, translating the scientific information on COVID-19 through local terminologies in ways that connected emotionally, created social awareness, and lay the foundation for public understanding. We had textile designers, funerary artists, playing memorializing functions. We had political cartoonists who focused on the structural context of health, risk, and behavior, reminding their audiences at home and abroad that public understanding was unlikely to inform sustained behavioral change without investments in health and social protection. Other artists challenged the global politics of the pandemic response. For example, two hip life artists, hip life is a genre of music in Ghana, it sort of blends high life and hip hop. So these two artists, Talenki and Opanka, performed songs in COVID-19 in English, Pidgin English, and Twi, a local language. The songs covered themes of prevention, but the lyrics also place the pandemic within the context of preceding pandemics and public health threats, swine flu, HIV, Ebola, and represented speculations and conspiracy theories circulating on social media, and in particular African Twitter, about the sources of the pandemic and about anti-African vaccine developments. On the surface, these songs fed into infodemics, the blend of misinformation and disinformation on COVID-19 that circulates social media throughout the life of the pandemic. But at a deeper level, both songs reveal the psychopolitics of the COVID-19 response. Talenki plays the Ghanaian story within the broader African context, with his references to white versus Black people. He bemoaned the Western interference in the lives of Africans, oh no, leave the Black alone. The song instantiated W.E.B. Du Bois's concept of double consciousness, the mode of looking at Ghanaian Black African realities through the lens of Western white power structures. These theories, were rooted in collective memories and rational fears, driven by historical and ever-present biomedical injustices, such as the French medics' casual project proposal of March 2020, and the persistent stigmatization of Africa as an infectious continent. And this is a clear example of the psychic life of the global health encounter. The kind of the transition from the psychic life of the colonial encounter to the contemporary global health encounter. So on the one hand, we have an established trope of Africa as an infectious continent, which causes symbolic and material harm. But on the other hand, local anticipation and understandings of this trope carry a conscientizing force in the sense that national and global health interventions are often questioned, shunned, or used strategically as part of a cultural bouquet of health solutions. This is not dissimilar. What happened during COVID wasn't dissimilar to several forms of resistance in the post-colonial era in Africa to global health interventions that are perceived to be harmful, from polio vaccines in Nigeria, Ebola vaccine development in Ghana, tetanus campaigns in Cameroon, to blood draws and associated biobanking procedures across the continent. The psychopolitical strategies employed by local communities are often steeped in collective and social memory. And they're often ignited during moments of personal, community, and national crises through traditions of songmaking, storytelling, dance, and what the social psychologist Sandra Jovcelovich describes as creative practices of the imagination. So since the COVID-19 pandemic, there have been calls to reimagine, restructure, sort of redesign health systems to meet the complex demands of current and future global health threats. Now, speaking, in the last couple of weeks, the world's been gripped by the hantavirus outbreak on a cruise ship, for example. Everybody's wondering, am I at risk? And we've got public health, experts giving us, a breakdown of how you might be at risk or not at risk. But for researchers developing sort of decolonial concepts and methods in global health, or focusing on re-indigenizing public health in local contexts, the argument is made that the global health imagination is framed by a distorted Western gaze and a limited set of scientific disciplines, and it tends to exclude social imaginaries and the creativity of the social, like what ordinary people imagine, see, feel, and want to create for themselves. For those working in the arts and health fields in Africa, there's been a long-standing argument that projects have to move beyond the banking method. Paulo Freire called the banking method, which assumes a know-all message source and a know-nothing message destination, towards a dialogical and people-centered approach to health communication, which emphasizes critical thinking embedded in the concrete existential present situation of real people. Dialogical approaches matter, whether projects are mass media campaigns or community-based participatory methods, whether artists communicate health independently or through government support. The dominant approach whereby local people participate in expert projects, theorists argue, must give way to experts participating in the projects of local people. So by turning the lens onto the creative resources ordinary people bring to their own representations of and practical responses to health, illness, and healing, experts can fashion more robust, dialogical, people-centered health communication models. What does this mean in practice? So in my book, I argue that we can apply the Akan concept of Sankofa as an organizing principle for reclaiming arts traditions for dialogical health communication and public health intervention. Sankofa means to retrieve in the Twi language. The concept is captured in the proverb, "It is not taboo to fetch what is at risk of being left behind." It is also represented visually in gold weights, in wood sculptures like the one on the slide, and textile designs by a bird that moves forward while turning its head back. Sankofa has become an organizing interdisciplinary principle for developing a decolonial and indigenizing approach to identity, agency, and social change for continental and diaspora African communities. In the book, I define Sankofa from a social psychological perspective, and I say it's a creative practice of the imagination and memory. It's a vital process of remembering, reclaiming lost and contested traditions within the boundaries of self, society, and culture, and activating these reclaimed traditions to serve contemporary needs. In Ghana, the Sankofa principle has always informed the workings of indigenous healers. Like the proverbial Sankofa bird that moves forward while its head is turned backwards, the reinvention of healing traditions requires that healers look back as they move forward. They often borrow strategically from eclectic sources to modernize their services, even as they protect the core functions of indigenous healing. That is, to address the interaction between the physical and spiritual dimensions of serious sickness. Indigenous healers utilize arts in the way that they perform their healing repertoires. The arts are utilized as a knowledge system in diagnosing and healing. They're representations of small gods, they're everyday objects loaded with spiritual power, small medical objects and spectacular machines, imported from, Asia, aid the performance of diagnosis and treatment. The Sankofa principle also informs the use of arts in everyday social life in Ghana. The arts underpin major life events in Ghana, from the celebration of births through outdoorings, marking puberty rites, markings, marriage ceremonies, and funerals. During these family and community events, there's a collective reflection of the power of the past weighing in on the present when ancestors are called through libation and the verbal arts, the use of proverbs, the retelling of clan stories. When formal speeches are enhanced with song and dance, when bodies are adorned with commissioned textiles or beads handed down generations, when family and gendered roles and functions are outlined through carefully curated color schemes, when specific cuisines are prescribed and consumed. At these events, art is truly participatory. Art also functions politically in family and community life. Individuals can subvert family and community norms and power dynamics for personal and group social capital. In Ghana, funerals bring this element to the fore very, very, very vividly. The art forms themselves change over time. New elements are borrowed, and meanings and forms of engagement change with social, economic, and political conditions. When activated positively, these art-based rituals mediate social connections and cultural renewal and push families and social groups into new relational spaces. They can create pleasure, joy, other positive social emotions that enhance well-being in specific moments, but also across time through shared memories. So in everyday life, in Ghana and other African sort of contexts, the aesthetic, spiritual, social, psychological, political mingle in healing and social spaces, making arts and social creativity powerful mediating forces for transformational health, communication, and public health. And this is also the reason why, when experts go into the field, aim to work with communities, it's important to understand that the arts-based communications have to be culturally grounded, and disciplinary and transdisciplinary, as well as community-led. So I'll end there and open up for questions. Thank you.